point. In particular, the management of spontaneous pneumothorax by thoracoscopy route. And I had a question this morning. What is the place of thoracoscopy in the management of pneumothorax? Good. But if you can answer what is the place of surgeon in the management of pneumothorax, I have no answer too, you know. Then we are in between. And then we have to discuss this point, for sure. Just to remind you that there is multiple controversial issue concerning the management of pneumothorax. I don't want to talk about the first episode of pneumothorax. Just briefly, I don't know if you are familiar with the recent literature in the field of pneumothorax, but for the first episode, the way is to prone a mini-invasive approach. Briefly, in France now, we never put a chest tube in the pleural cavity for pneumothorax, and because it's painful, it doesn't make sense, and I don't know if you read the last editorial I wrote in the European Journal of Cardiothoracic Surgery. It was, I think, in March or April. I think it's a play for mini-invasive approach of the pneumothorax because there is no proof. There was no proof that chest tube insertion is relevant for the management of pneumothorax, you know. I mean, primary spontaneous pneumothorax. But conversely, at that time, there is plenty of study, comparative study, showing that the mini-invasive approach, I mean exsufflation, I mean in-wheeling pleural catheter, it's enough in comparison to chest tube insertion for the first episode. But it's not my talk today, but we can discuss this point if you want. The other important controversial issue is, of course, the management of recurrent spontaneous pneumothorax. I mean, is there a place for thoracoscopy? Is there a place for surgical thoracoscopy? Is there a place for BLEPS or bular resection? Is there a place for talpoudrage, etc., etc., etc.? So far, there is no study showing that a management, a procedure, is better than another, of course. And then we can assume that so far there is a place for thoracoscopy in the management of pneumothorax, and the surgeon can talk also about this point, saying that there is a place for the surgical management of pneumothorax. But the problem is actually the place of talc pleurodesis. I would like to stress 2 points. The first point is the efficacy of talpoudrage in this field. And the second, it's the safety of talc, of the decalcitrant talc, which was a very controversial issue, but so far it's not relevant, I think. Then just to remind you that recurrence rate after single rest, oxygen treatment or drainage, it's around between 20 and 55% within 2 years, actually. And the recurrence rates depend the time, it's maximum within 2 years. Depending on the patient, it's more frequent in male than in female. And depending on the morphotype of the patient, I mean, you know that the long and thin guy are more relevant to present a recurrent spontaneous pneumothorax. Of course, the first episode also is depend of the smoking habits of the smoking behavior of the patient. In particular, we know that it's increased the first episode of pneumothorax, but so far there is no proof that the smoking behavior has an influence in the recurrence of the pneumothorax. There is no study concerning this point. The two important messages, I think, in this field are that the recurrence rate is independent of treatment without symphysis. Whatever the mean you use for the treatment of the first episode, I mean rest, observation, oxygen, chest tube induction, chest tube insertion, exsufflation, etc., etc., there is no difference in terms of recurrence rate for pneumothorax. And the recurrence rate, it's independent, and shown by multiple studies, it's independent of the presence of bulla, which is also important to discuss about the relevance of the resection of bulla or BLEPS on the surface of the lung. Just, you know this picture, I remind you the four features concerning spontaneous pneumothorax, the so-called normal appearance of pleural cavity, but if you take a closer view, you can see here very small blebs near the fissure. At this level, you see here anthracotic deposits on the lung, which is very frequent. It's not a heavy smoker, obviously, because I can tell you that the patient with one pack a day have a very dark lung. But there is a few blebs here. There is a type 2 with adhesion. Just, I repeat, check carefully the basis of the adhesion, because sometimes you can have air leak at this level, which is important to know and to treat. You can coagulate, for instance, using a second point of entry. You can put the coagulative forceps inside and very gently coagulate this. It's easy to do, and it's important to do. The other, it's a type 3 from Van der Schuren classification with presence of blebs of the surface of the lung. I just what to say? I just would like to say that there is no connection between the blebs and the tracheobronchial tree. You know, it's kind of hernia of the visceral pleura, and consequently there is no connection between the airflow and this abnormality. Conversely, there is connection between tracheobronchial tree and, of course, this so-called emphysema-like changes lesion at the surface of the lung. Then, obviously, there is an air leak due to a lesion or the surface of the lung, but which kind of lesion it is? Is it a microscopy lesion? And we know from very old study carried by a guy from the United States in 1937 that pneumothorax without visible lesion on the visceral pleura exists, but without visible lesion. It doesn't mean that there is nothing, and more recently by electron microscopy we see lack of mesothelial cells on the face of the lung, the so-called elastofibrosis, and also the stoma on the surface. Of course, it's not the same stoma. It's not the stoma from the parietal pleura. It's not the stoma connecting the pleural cavity with the submesothelial lymphatic vessel. There are dehiscence between two mesothelial cells in this case, and due to difference in terms of intrapleural pressure, you get an invasion of the pleural cavity by the hair, etc. It's dehiscence between two kind of cells. If you want to see what's happened microscopically, you have here the basis of a giant bulla with generated intratrabecular structure of the bulla. You have here the so-called elastofibrosis, which you see lack on the visceral pleura, which is a stoma on the visceral pleura, it's easy to understand that in case of high level of intrapleural pressure or intrathoracic pressure, you can get air from the inner part to the outer part of the lung through the visceral pleura. It's well described. What is the best procedure to prevent the recurrences of spontaneous primary pneumothorax? We have two solutions. Or we can treat pulmonary abnormality, the so-called emphysema-like change abnormality of the surface of the lung, I mean blebs, I mean bulla, or we can treat the so-called pleural porosity of the visceral pleura due to this dehiscence between two mesothelial cells at the level of the visceral pleura. Or conversely, is it relevant to treat only the pleura? I mean to apply talc or other stuff inside in order to get pleurodesis, or both. And we'll discuss this point maybe. If you look at the literature, there are very, very, very few comparative studies concerning the treatment of pulmonary lesion on the surface of the lung, and we do not know if it's efficient, because I found only 5 studies, you see, this kind of study, but sometimes it is historical comparison, and in evidence-based science it doesn't make sense to have a comparative historical study, of course. But do you see, for instance, in this paper, Ferguson in 1980, 0% recurrence after resection of the suspect urea, but the cohort was 249 patients with conservative treatment. We do not know why in this paper, and 45 patients and 15 on 45 prolonged bubbling, and 30 on 45 other, but we do not know, we don't have any detail, and I think there is a bias in this study. In this other study, as you can see, there are 5% of early recurrences and 5% of late recurrences using only bulectomy without prodesis. The others are the same, as you can see here. Here it's fats with single bulectomy, 4.6% of recurrence. It's a surgical team. And conversely, with single prodesis, 0 degree, but it is not comparative. So we cannot draw something from this study. It's only experience from several teams. It's not very relevant in the evidence-based fashion. What we can say that it's most of the patients with primary spontaneous pneumothorax have a visible lesion on the surface of the lung. If we use direct vision or conventional CT scan, it's around 15 to 65% of patients. But if we use more sophisticated methods, as during VATS or last generation CT scan or during thoracotomy, it increased dramatically with 75% to 100% of patients with visible lesion of the surface of the lung lesion. And conversely, in control patients, taking into account the age, sex, and smoking behavior, only 25%. Maybe it means, but we do not know, that, of course, abnormal macroscopical lesion of the surface of the lung is something available in saying that it is relevant to resect it. But we do not have any study showing that the treatment of these abnormalities is efficient, and the surgical team have around 5% of recurrences, mainly late recurrences. And but conversely, we can say that recurrences after VATS are more frequent if the lesions are not visible or cured. It's one study by this surgical team. But I think the two main important points are from a study carried out by Mark Knoppen from Belgium and Jules Janssen from Nijmegen, the Netherlands, found that there is no relationships between the number and size of the lesion and the pneumothorax episode. And the second point is that there is no difference between the number and size of the lesion for the first episode in comparison to the recurrence. If this study was carried out by Paul van Schuil from Belgium, it's a very, very clever thoracic surgeon, very, very nice guy, and he collects all this study concerning the procedure after the the management of recurrent prothorax. As you can see here, if we look at the series concerning the single treatment of abnormality of the surface of the lung, I mean visible abnormality, macroscopical abnormality, you can see that the recurrence rate it's around 15%, which is very high in this series. And maybe it's the reason why, for instance, this study by Cardillo from Roma, it's a surgeon and collects his own series, and as you see, there is after bulectomy and pleurectomy, there is 9% recurrences, but it's a thoracic surgeon. There are huge experience. Giuseppe Cardillo in Roma, a huge experience in the field of pneumothorax. He is the chairman of the new guidelines for pneumothorax. I am enrolled in this group, ESTS group, and you will have in the next September the European guidelines concerning the management of pneumothorax. And he applied talpoudrage, and you see, but it's also not available because it's historical comparative study. But it's the reason why some surgeons add to their bulla or blebs resection prodesis tool in order to improve their resistance. Because we can have this state of spirit if we think that bulla or blebs are responsible of the episode of pneumothorax. Why add something after resection of the bulla or bleps, it's not useful. But maybe it's not enough. For instance, this patient with pneumothorax, as you can see here, there is a bulla here, there is a bleps here, and for sure, this bleps on the apex, it's not responsible of the episode of pneumothorax because it's plenty of hair and there is no fistula at this level and maybe something other happened. And for sure, if you cut this, maybe you can miss other parts of the pleural cavity. I'll be back on this point a little bit later because I think it's very important. Same for that. A thoracic surgeon manages this patient with a recurrent spontaneous pneumothorax, and as you can see here, he resects lung, he resects bleps, bulla, etc. But for sure, these bulla are not responsible of the pneumothorax episode because they are full of air, and then there are no leak, and then there is no problem at this level. Maybe there is another problem on the other parts. And just I would like to show you this very, very nice study by Mark Knoppen from Belgium. Look at on the bottom of this picture. You can see here a pleural cavity with bleps on the surface of the lung. It's the same here. As you can see here, there is a giant bulla here, of course. If a surgeon managed, and it was the case in this situation, if the surgeon manages this bulla, he's going to perform a surgical thoracoscopy, that is going to resect this part of the lung. If you look at the same picture using fluorescence autofluorescent thoracoscopy, you can see that you see fluorescein here only due to the porosity of the visceral pleura I was talking about a couple of minutes before. It means that the surgeon is going to cut this at this level, but left in place the bad part of the lung which is responsible of the pneumothorax. If it doesn't apply a pleurodesis technique, I mean pleurectomy, pleural abrasion, etc., it will be not enough. It will be not enough to cure the patient, and maybe the problem is at the level. Conversely, the symphysis with TAL, for instance, of abrasion should be relevant because it's microscopic abnormality of the surface of the lung, the kind of elastofibrosis, this kind of pleural porosity, and that it should be relevant also. And then if I summarize this busy slide, I'm sorry, but just we can see together what's happened in patient with pneumothorax. You have a pressure gradient, whatever the etiology of this pressure gradient, and you can have a bronchial abnormality, you can have airway obstruction. There are plenty of studies showing that the prevalence and the incidence of pneumothorax in patients with asthma is very high. Usually it's infraclinical asthma, and in our study we perform in Marseille, we check the reactivity of the bronchus using metacholine process to see if there is bronchial hyperactivity. And you have a kind of valve mechanism, and depending also of quality of the connective tissue, the so-called emphysemal exchange, pleural porosity, you can get air leak at the level of visceral pleura. However, the alveolar rupture are very rare, and in my life, it was very rare to find macroscopic air leak during the management of spontaneous pneumothorax. We know also that there are other factors influencing the pneumothorax, the physiognomy of the patient, the heredity, etc., etc. We know that sound could be a predictor of pneumothorax, in particular the rock group. It was very well studied. The localization of the air leak is difficult to assess because the rupture of true pulmonary lesion is very rare. Mainly it is due to the pleural porosity, the so-called elatofibrosis. The problem is that we know that the surface of the blephs and the surface of the visceral pleura are porous too, but also there is porosity at the distance of visible lesion, and on the surface of the lung without visible lesion, it is a problem, and you can miss this special area of the visceral pleura during the management of recurrent spontaneous pneumothorax. And then, of course, we are involved in this field of the management of the pneumothorax by thoracoscopy route using talpoudroage. You are familiar now with this double balloon system we use in Marseille. It's not single-use double balloon system. It is a talc atomizer here, and we can gently spread the talc on the surface of the lung, as you can see here. But the question is, and you know that talc is a very controversial issue, and some people assuming that it can induce granuloma, it can induce cancer, it can induce functional sequelae, and mainly it can induce acute respiratory distress syndrome. Concerning the granuloma, using for pneumothorax 1 gram and for pleurisy 4 gram, you rule out the problem of granuloma. You cannot get granuloma with such amount of talc. It's a first message. Cancer, of course, it's asbestos-free, dedicated cult. I just was talking about this point because you know the bad reputation of talc came from the old American study using talc from New Jersey. And the talc from New Jersey was plenty of asbestos fiber, and for sure 10 years, 15 years later, the people developed a mesothelioma. It was experimental study on mesothelioma, you know. But the problem is that the bad reputation of talc in the United States came from this use, which doesn't make sense in 2010. What about the functional sequelae? We know from multiple studies, but just I show you a very old study we did with my mentor, Professor Boutin. We check the chest X-ray in patient after talpoudroage, and we compare the two sides. As you can see, in 85% of the cases, the chest X-ray was normal. We find in 5% blunt costodiaphragmatic angle. We find in 5% apical pachypleuritis, in 5% parietal pachypleuritis. And when we compare diaphragmatic kinetics between homolateral side, talc poudroage side, and opposite side, there is no difference in terms of kinetics at this level. And more recently, this paper by a Belgium team showed that 1 year after talpoudroage, the total lung capacity was normal. There is no restrictive syndrome 1 year after talpoudroage, but also, as you can see here, 3 months later, it was okay, before for sure, etc., etc. And then functional sequelae are not relevant for this patient, and they're going talpoudroage for spontaneous pneumothorax. The main point maybe is acute respiratory distress syndrome, because there is plenty of paper showing that after talpoudroage you can get respiratory failure. In particular, this paper by Ricci, it's a surgical team who found 30% of respiratory failure after talpoudroage. But this kind of study makes me very upset, you know, because it's a conclusion of the paper. But if you carefully read this paper, you see that, one, this guy applied talpoudroage after pleural abrasion. It means open the vagostoma very deeply, very largely. Second, use 10 to 15 gram of talc, and put 2 or 3 points of entry. It was surgical management, and then it's not our procedure for sure. It's not medical thoracoscopy, it's VATS, I don't know why, but it's not relevant. Because conversely, our team in Marseille, this team, Weisberg, it's the guy from Israel, Francisco Rodriguez Panadero from Sevilla, and Giuseppe Cardillo, which is a surgeon in Roma, never see one single case of acute respiratory distress. I never seen one single case in my life of acute respiratory distress syndrome after talpoudroage. And if we look at the literature, this study carried out by Richard Light and Stephen Sand, it was a pro-con discussion concerning the safety of talc. If you look at the literature, you have around 0.71% of ARDS described in the literature. It's not due to the metal, because you can find after talpoudroage. It can happen with few amount of talc. And then the problem, then it's not this. maybe it's a systemic distribution of talc particle. Few team in this world found from clinical observation and also after experimental study, in particular this team from Brazil, show after experimental study on animal applying a talc poudrage, more than 100% of organs with talc particle inside. It's the reason why we did this study 8 years ago. It was one of my assistants, Anne Fraticelli, and we did the same study in rats using French dedicated talc, and we found 0 particle in organ. It means that the talc preparation, you know, are different. And I asked a friend from United States to send me US talc, FDA approved, as you can see here. And the problem is that in US talc, you found more than 30% of particle under 5 micron in diameter. Conversely, you see the French talc, it's only 3%. It means that the talc preparation from the United States have very small particle size. And more recently, this team from Spain, it's a light connection too, compare several preparation of talc. You see here A, B, C, D, it's US talc, E, it's talc from Spain, F, talc from Brazil, G from Taiwan, and H from France. As you can see here the French talc, it's bigger. It means that the problem is not the amount of talc, but maybe it's the size of the talc particle. And then if you look at this busy slide, I'm sorry, you can see that, for instance, just look at this part. You see here after management of talc, you can see that this team got 6% and 12% of deaths after talc poudrage, which is incredible. Of course, if I have one single case, I stop thoracoscopy at poudrage the same day, I can tell you. But if you look at the talc he used, you see that he found 12% of deaths after talc poudrage with preparation with more than 90% of talc particle under 5 micron. It was talc for cosmetic talc, you know. And same in this case with 6% of deaths after poudrage, around 80% of talc particle under 5 micron. Conversely, we talk with no problem concerning the size of particle, 0. Then the size of the talc particle is important. Why is it important? The first step is that we did this study on goats with my colleagues, my collaborator in Marseille. We used 9 goats, you know, and we performed talc poudrage on the side and talc slurry on the other side. And in both sides, D0 procedure in left side and day 14 on the right side. We used 2 grams of talc from Novatec company. It's a French talc from Steritalc. And we performed bronchoalveolar lavage and blood samples before procedure and after procedure. It was a huge job at 2 hours, one day 1, day 3, day 7, day 14, etc., till the day of sacrifice. And then we check the talc particle by microscopy and porosity light microscopy, and we compare these two procedures regarding two process, I mean talc slurry and talc poudrage. What we found, no talc particle in 16 samples, no talc particle in blood, no talc particle in bronchoalveolar lavage. What about the comparison in terms of pyrodesis score? We use the light pyrodesis score and Henry Cole pyrodesis score. As you can see here, there is significant difference in terms of quality of the symphysis between day 14 and day 28, which is logical. But if you compare the difference in terms of quality of the symphysis between talc poudrage, and versus talc slurry, you find a significant difference in favor of talc poudrage, total significant difference, but also at day 14 and at day 88. It means that the talc poudrage it's more efficient than talc slurry. And I can tell you, you have here a goat's 30-day after talc slurry. As you can see here, there is no adhesion. You can easily induce artificial pneumothorax 30 days after talc slurry in normal pleura. It's a model of pneumothorax in this case, no adhesion. Conversely, after talc poudrage, as you can see, it's impossible to create an artificial pneumothorax. You can go into the pleural cavity. It's impossible. And if you compare the thing, you see that it's better. The symphysis is better. And I think it's interesting to see that if you look at the microscopical aspect of the pleura after talc poudrage, you see here a thickness of the parietal pleura. You have here a thickness of the visceral pleura. You have in between the pleural cavity with talc particle. If you take a closer look using polarized light, you can see in between talc particle, and you know that there is no talc particle outside the pleural cavity. And the inflammation is on the parietal pleura, on the visceral pleura, but there is no problem beyond the androcystic fascia I was talking about a little bit earlier in this morning. And if you compare the thickness of pleural symphysis, talc poudrage is superior to talc slurry, as you can see here at day 14, at day 28. It's clear. And that, what is the cause of the acute respiratory distress syndrome? It's not related to the systemic distribution of talc particle, but for sure it's due to the size of talc particle. And this nice study carried out by Nick Maskell from Bristol, who attended twice a thoracoscopy course in Marseille, and I was very happy glad to see that he continued to learn pleural disease, etc. He compared to a very, very simple study, but very interesting study. Using mixed talc and grade talc, I mean calibrated talc, he checked the change in alveolar of arterial oxygen gradient. He checked the change in arterial PO2, and he checked the change in plasma C-reactive protein. As you can note, briefly to summarize, the inflammation is most important using the grade talc, non-calibrated talc in comparison to the other talc. Same concerning the level of inflammatory reaction, as you can see here, with grade talc, with mixed talc in comparison to grade talc. And then the acute respiratory distress syndrome is not the consequence to the dissemination of talc particles, but it's due to the size of talc particle. And I just would like to finish my presentation just to say something maybe which will be more clear to summarize. Okay? Can I use this?
Is it working? It's not. I'm not sure. It's working? Sorry. Same amount. For instance, 2 grams. Okay? Same amount of talc. Here, small talc particle like this. Here, regular talc. Here, big talc. But for the same amount of talc. It's easy to imagine that the inflammatory reaction and the cytokine cascade due to the surface of the talc. You add all this surface here, and And then you get surface 1, here surface 2, here surface 3. And if you had all the surface here, of course surface 1 will be superior to surface 2, superior to surface 3. It means that the inflammatory reaction, depending on the surface, will be higher with this in comparison to this, in comparison to this. Okay? It means then you can get problem is the inflammation will be very important, and then inflammatory reaction also very important. Okay? If you take this, of course, the surface, the inflammatory reaction will be very low, okay, but the efficacy very low too. It means here, very huge symphysis, but the risk of RDS is high. Here, but very efficient for symphysis. Here, inflammatory reaction very low, but inefficient for cross-symphysis. And then you need calibrated talc, kind of balance between the good symphysis and the good without safety. Okay? You understand? It's the reason why. And I missed, the study we did published in Lancet, so you know the study, more than 558 patients, prospective study, involving 12 centers in Europe and 1 center in Africa, in 558 patients. Calibrated talc, program of talc, also for
small, tiny question. Small, tiny problem. We don't have talc in Egypt.
Mm-hmm.
So what is the solution for us?
For you, the solution is to use the former drug as tetracycline, as maybe bleomycin, but we know that it's less relevant.
We here our institution you are used to use the iodopovidone and got a great success rate with us. But I don't know if it will work with pneumothorax or not.
No.
No.
No. You read, I think, the next issue, or within 2 months, is an editorial from European Journal of Cardiothoracic Surgery. No, it will be published within 2 years, because I correct the proof the last week. it was concerning, but it was a study from Egypt, because he asked me to write an editorial concerning a randomized study from Egypt concerning the use of iodopovidone versus talc. It was talc poudrage. And you see the editorial. The problem is that for pneumothorax, you can get a secondary effect. In particular, cecity, loss of vision after iodopovidone. It's very well described. You have a lot of paper concerning the visual loss after iodopovidone in the pleura. You know this complication?
No,
yes. There is paper. May I have internet access here? Just we can check if you want.
The only complication I know if there is some pain or the patient is goitrous or have thyroid.
It's very painful. It's very painful.
Yes.
painful. The first, there is no comparative study. The study done by colleagues from Egypt was a few number of patients. My purpose was not to review the paper. It was to just write an editorial because it was accepted. The paper was accepted, and then you can read this. The team was from, I don't remember, from Cairo. From Cairo.
We are from Alexandria, okay?
Mm-hmm.
And we are using this substance since 2006. We have been using this substance since 2006.
Which substance?
Alexandria Medical School.
Mm-hmm.
Okay, so we are using this. We have been using this substance from since 2006. So I've been using for 5 to 6 years and gained a great reputation.
It's Parisi or pneumothorax? In a spontaneous?
No, in most of the cases in the pleural effusion, not.
Actually, I have no experience in this
We
field.
have a problem. We didn't publish our paper.
But what is the reason do not have talk? Because it was the same in Japan, for instance. I was invited in Japan. It was 5 years ago with the Ministry of Japan to discuss this point. And now it's available since the last year in Japan, because now we have enough data concerning the safety of talc, etc. in pneumothorax. It perceived with a lot of paper in Lancet, in New England Journal, in etc. etc. I think there is no reason, and I suggest to all the pulmonologists to push this, because I'm sure there is no reason to rule out the talc, because it's the most safe. It's safer agent for symphysis, I can tell you. But the problem is before this, I don't know, if you have your practical, you are satisfied by your method, use it. I don't know.
But maybe you experience in pneumothorax.
But you can, in pneumothorax, you can do the same as a surgeon. You can abrade the pleura. We designed a pleura abrader with Boutin. It was 15 years ago, and we did around 80 patients with pneumothorax. But it took a long time, etc., etc. If you look at the literature, there is an experimental study comparing pleura abrasion using a abrader and talpoudrage. Of course, histologically, the pleurodesis after poudrage is better than pleura abrasion. We know, but it's better than tetracycline and bleomycin. You understand? Chemical drugs.
5 years before, in the year 2005, I was searching for a talc abroad, and the only one I found, the sclerosol, was 40 euros per pack, and the patient usually needs 1 to 2 packs to use. But I'm astonished now when you are saying that its price is 10 euros only.
But it's 10 euros a bottle. If you use a disposable canister, etc., it's around, I think it's 40 euros.
No, we have the atomizer, but we are using.
It's not atomizer. It's a new. It's a disposable use with a balloon inside, etc. It's very sophisticated stuff.
What is the name of this 10 euros canister?
10 euro. It's not canister. 10 euro. It's just the bottle. You know. We use this. I just would like to show you maybe. Actually, we have a bottle of it's two kind of bottle, 2 grams or 4 grams, okay, and we put the talc in this device. It costs nothing. It's 10 or 15 euro. It's nothing. This we put the talc inside here, and you use a double balloon insufflator like this. But the bottle are 10 or 15 euro, I think. But since it's reusable, you have to sterilize. You can sterilize this one. It's okay. Otherwise, you have now disposable system with a single balloon. It's a blue one with a small bottle, etc. It's around 40.
Can you tell us the trade name of this?
It's from Novatec company. It's
Novatec?
Yeah, it's
from the company or the trade name.
It's a Novatec company. It's Novatec company.
You see the company, the name of
The name, but you know, disposable talc poudrage system, it's okay, there is only one. it's it's not uh, uh, it's not required, but you can. Usually what I do, I put a needle, plural needle inside, and I connect this stuff with a plural needle, and I make my poudrage under visual control, as you can see here. No, not necessarily. You can spray like this and just take a look if you have enough talc, or if you gently spread on the surface of the lung, etc., etc. Any other question, please? For children, it's small size particle. Don't use, please, because it directly. Don't use. It's cosmetic talc. No. It's formally prohibited. No, don't. It's very small talc, very small talc particle. You have after that you have an intense inflammation, very huge inflammation. No, don't use it.
I want to ask another point, including malignant pleural effusion.
Yeah.
The decision of talc poudrage, does it depend on the extension of the lesion, on the view of the extension of the lesion during thoracoscopy? Can it change my decision about protesis? I am asking about the effectiveness of talc protesis in correlation with the extension of the lesion, extent of the lesion in the pleura.
It's a good question. Actually, to have a good pleurodesis, it's okay. Thank you. To have a good pleurodesis, you have to still remain mesothelial cell, LC, because the fibrotic process, it's induced also by mesothelial cells. And you are right. If you have, for instance, large pachypleuritis with fibrotic, etc., you can be your procedure less efficient, actually. Okay, but if you indicate therapeutic thoracoscopy for talc poudrage, when you perform thoracoscopy, you perform your talc poudrage. You understand? It's the reason why you don't have to wait too much. It took a long time in France, in Marseille in particular, for the physician refer the patient early. You understand? My opinion is that after 1 or 2 thoracentesis, within 1 month or 2 months, you have to go to the talc poudrage. Otherwise, you have a spreading of the nodules of the disease into the pleural cavity and make your procedure less efficient. I think it's an important point. You are right. Any other question or comment? Someone advised me to stop at 3 o'clock. We have 35 minutes. It's good. Just maybe for you, I found interesting to show you an entire procedure. I have a video. Maybe it should be good for you, and you see familiar slides, etc. But I have a video. It's an old video I did, but I think it should be interesting for you. I need the sound. And, okay, good. I think it's okay here, like this. I think it's okay. Let's see. Yeah, sure. Yes, it is. Maybe I can, but maybe. Okay, good. It's good. Maybe I have to. Yeah. Maybe we. Maybe we need also a full screen. I don't know, because I'm not fluent in Arabic characters. And the second one. This one. This one. It is full screen, maybe. Just I start the video, and you put the first screen for us. Thank you.
Okay. Okay, but it's our nice city, Marseille, as you can see. It's my former hospital, but anyway, just in a few seconds. Just a video to show you all the tools we need, etc. in the entire procedure from the beginning. Okay. Okay. Then it's a basic equipment, as you can see here, lidocaine, because you can perform this procedure under local anesthesia. You have the pleural needle here, and everything to dissect the pleural cavity. The 7mm trocar, the 5mm insulated trocar, the 7mm trocar. 5mm insulated trocar, so you can see here. You see, it's for insulation, you can coagulate with. Anyway. Just you can put the coagulating forceps in this 5mm trocar. Then you use a telescope like this, putting a 7mm telescope with 0° angle, as you can see here. It's okay. I can make a comment. It's your basis set. You know, it's oblique one. As you can see here, it's a 45° telescope. It's optical forceps. I was discussing here with a lady who was here. In order to make, you cannot coagulate with this optical biopsy forceps, of course. It's a cleaner, actually. It's just you put a swab here and you can clean the trocar in case you have blood, etc. It's a very simple device, but it's very, very nice, because sometimes you are boring by blood, etc. You can use other tool to severe adhesion, for instance, this hook, but it's not basic. It's coagulating forceps. This, it's important for coagulation with the tip of the forceps or to lung biopsy, and it is endoscopic needle to make a puncture of lung mass, for instance, of pleural mass. And you have also a Caesar, endoscopy, etc. But it's not a prerequisite. It's not useful. More than 95% of a procedure are done very simple. It's a pleural abrading for abrade the pleura we design, as you can see here, but it takes a long time, and we left. It's a double balloon insufflator for talc, as you can see here, and you see the talc very gently spread into the cavity, you know, and you run. It's a chest tube introducer. You put this inside, of course, and we put the chest tube like this in Marseille when we need the insertion of a tube, mainly at the end of the procedure. Sometimes, in case of huge proliferasion, very recurrent, we add extra hole on the lateral part of the chest tube in order to improve the drainage. Introducer, it's basic approach of the pleura. For sure, you know this. Which is interesting is that introducer is flexible, and you can do what you want in order to proper position to put. It's my mentor, Professor Boutin, as you can see here. I was the last week with him for a dinner. It's my second father, actually. I'm the only professor from here, from him. Of course, this tool here, it's important. It's a warmer. And during the procedure, we keep the telescope in 37 degrees. And then it's good because it's, in particular, in local anesthesia,
fluorescein patients
allow you to avoid the patient coughing, etc. But degrees, which is good. Yes, you can. You can use warm saline now, etc., etc., if you want. Okay, it's a patient position lying on the healthy side. We dropped everything like this. It's Ghislaine, the nurse. Oh, it's okay. I can comment so far. Okay. No, it's okay. No, it's okay. I did like this. The first step maybe it's to count the intercostal space. The first you feel in the axillary line is the second intercostal space. And you count second, third, 4, 5, 6, 7, 8, 9. The lower part it's a 10. And then you count 10s, 9, 8, 7, etc., etc. And it shows, I repeat, third or fourth intercostal space for pneumothorax, and 5, 6 for the recurrent pleural effusion. First step is induction of a pneumothorax, artificial pneumothorax, using the pro needle, as you can see here. You put the mandrel with a sharp tip to go through the skin, and you replace it by the point versus blunt one in order to go through the pleura, actually, as you can see here. And you open the top and the air going through. You can check the pleural cavity. You get another device. I didn't talk about this device, but we left this device. You see, we make a graduation like this. We connect this, and we see the same. The zero is at the level of the needle, the same. Okay, but we left. And you have to get a pocket, a pleural pocket, in order to make a good analysis of the pleural cavity. Usually 10 centimeters is enough to have a good access. You see all the sets here, very simple sets. We are not in a surgical operating room. First step is to check the pleural cavity. You always perform a local anesthesia, even the patient under general anesthesia, because we feel the pleura, we feel if there is an adhesion or not. Checking with the syringe if there is a bubbling. We see this with the dog tomorrow. Okay? No, we don't. You don't insufflate the pleural cavity, never, because we find that it's safer. And you see here, you can check. You make a gentle incision, less than 1 centimeter incision. You dissect the pleural, the chest wall, never cutting inside. You just, it's blunt scissors. You put the 7 millimeter trocar inside, and then the procedure is finished. Because after it's nothing to do. You remove the fluid from the pleural cavity, as I show you. You aspirate all the fluid in order to get a good pleural cavity for analysis. And after you put the telescope inside and you check the pleural cavity. We record all our procedure. We record all the procedure. We have the camera and we record everything. Just to see, and sometimes the surgeon asks me, "Did you record this?" Because we have etc. And this is good. This is good. You see here the upper part of the lung with an adhesion here. You see the posterior parietal pleura, intercostal space with vessel, the rib, the lung, the diaphragm, fibrous part of the diaphragm, muscular part of the diaphragm, the pericardium, the pericardiac fat, anterior parietal pleura, internal mammary vessel here, 1.5 centimeters on the lateral part of the sternum. In addition, on the apex, we clean the 7 millimeter just in case it was bloody. Okay? Simple device, but it's very useful, actually. Very, very useful. And we check everything on the screen. We have two television inside, etc., etc. And then it's just a simple examination of the pleural cavity. It's in front of the patient, yes. the other guy, it's back to the patient. You see, you know this figure, you see this diaphragm with nodule on the diaphragm, the costodiaphragm gutter, the posterior parietal pleura, diaphragm, invaded diaphragm, costodiaphragm gutter, and the inferior lobe, pericardiac fat here, the pericardiac ligament here, inferior lobe, atelectatic lung, middle lobe, upper lobe. You can do whatever you want, but now with the new device, you can just catch a picture directly from our camera. Very more sophisticated approach now, and you use optical biopsy forceps. You see, to sample the posterior parietal pleura. The lady left. It's peeling biopsy, as you can see here. Specimen, you see the peels of pleura, you can hear the specimen, and then you make your pathologist happy. Busy. You see? And as the pleura looks like normal, we take a lot of specimens, sometimes it's around 30 specimens like this, it's quasi-partial plerectomy, you know. Second point of entry, you know this video you already seen in my presentation. Second point of entry was a 5 mm procore from outside. You have the lights, you can see the light. In this case, it was a bleeding part of the lung, but there is no the sequence on this video. Just to show you the second point of entry. It was nodules on the pericardiac fat